really astonished with such wonderful organization and the generous invitation of my dear friend Dr. Peyronie and Professor Osama. It's really nice to have an oncologist among urologists and andrologists. My task today is to let the voice of my young male cancer survivors heard to the community of the expert urologists and andrologists. As you know, living beyond cancer is a reality. Cancer survivals approaching nearly 12 million in the United States. It has become clear that sexual function is often profoundly disrupted by cancer treatment. All of the modalities used to effectively treat cancer, including surgery, chemo, radiation, hormonal therapy, have the potential to significantly impair sexual function, an outcome that often remains a distressing and unresolved reality for cancer survivors. There is a huge need to not only understand how various cancer treatments affect aspects of sexuality, but to move toward effective assessment and targeted interventions that address cancer-related sexual dysfunction. Given that sexuality comprises psychological, relational, and structural elements in addition to physiologic factors, it is critical to embrace, like Professor Osama in his nice introductory talk, an integrative biopsychosocial approach to understand and address this fundamental aspect of survival's experience. As you can see, it is not one problem, it is not one factor, it's a lot of things. What about sexuality and men's cancer? Prostate cancer is the second most common type of cancer diagnosis, and treatments frequently lead to erectile dysfunction as well as loss of penile length, loss of desire, loss of orgasmic satisfaction. Despite modifications and surgical techniques to reduce the morbidity, sexual problems remain a pervasive and distressing adverse effect of radical prostatectomy. In addition, radiation therapy for prostate cancer, both external beam and brachytherapy, can lead to erectile dysfunction with the highest rates redundant from external beam accompanied with brachytherapy. Hormonal therapy make the situation more complex. What do we need? We need a screening tool. To date, there is no gold standard for screening for sexual dysfunction in cancer survivals. However, several psychometrically valid screening tools have been developed, and recent review of sexual function measures for cancer population point to two brief self-administered tools, one related to University of California and the other one is the International Index of Erectile Dysfunction. There is also growing attention on the use of patient self-report assessment to enhance patient provider communication. It has been shown that a majority of patients with cancer will endorse sexual problems on a self-report symptom list that had previously gone unaddressed. It would likely be beneficial to adapt such patient report outcome measures for assessing sexual morbidity for cancer survivals to cue providers that they need to address these issues openly with their patients. What do we need? For male survivals, the bulk of interventions have been medical trials of phosphodiesterase. The second-line treatment involves a lot of penile injection. Men on anti-androgen therapy are also treated with oral agents and injection therapy. Although penile implant surgery, to your knowledge, is well-recognized treatment for erectile dysfunction and a viable option for male cancer survivals who find that non-surgical options are either ineffective or undesirable, it has been shown that uptake of penile implants is uncommon. I'll repeat this again. It has been shown that uptake of penile implants is uncommon. In a recent large-scale study using SEER database, the use of penile implants following prostate cancer treatment, less than 1% of men registered a claim for implant surgery. Can you imagine? In the second most common cancer in males, 1% of those surviving their malignancy registered a claim for implantation surgery. Why? Lack of uptake may be due to the invasive nature of the procedure, as well as inherent surgical risk. This is maybe the cause, or lack of awareness. My take-home message is, sexual dysfunction is one of the most common and distressing consequences of cancer treatment. Although some treatment-related sexual adverse effects are short-term, many survivors face long-term effects such as treatment-induced altered gonadal function and significant surgical disfigurement. Profound sexual dysfunction has been shown to have a significant negative effect on quality of life. Although these problems have been well documented and there are a range of intervention strategies that can help patients cope with them, many survivors do not feel prepared for potential sexual change and often do not receive adequate support to manage sexual dysfunction. My last take-home message is oncologists, andrologists, and patients' advocates need today to set their agenda to tackle this challenge of underserving this evolving community of cancer survivors. And thank you.